everyone. Welcome to Preemie Chats. Thank you for joining us today. This is a program that is for healthcare professionals and for families to talk about what matters most to us, to share ideas and to learn together. I'm Leah Whitehead. I'm the proud mom of a preemie 28-weeker Tessa. I'm a former journalist and I'm happy to be your host today from Halifax, Nova Scotia. Preemie Chats was created and is put on by the Canadian Premature Babies Foundation, also well known as CPBF. You can visit their website at canadianpreemies.org to learn about how they are a parent-led organization that helps families in and after NICU through education, support, and advocacy. If you have a heart for preemies, whether you're a family or healthcare professional, then head on over to their website, and there you'll find resources, the latest projects, and most importantly, a community of people who want to see our little ones thrive. Today's session is live, so I'd invite you to please let us know in the comments where you're watching from. It's always interesting to see where people are viewing the program from, and also share any comments about your personal experience or questions you might have for our special guest today, because it is through rich conversations like the one that we're going to have today where we can advance practice and learn together. So please, every voice is important to come to the table and participate with us. I am really excited about today's topic today because in the world of neonatology, I think people can all agree that breastfeeding gives some key medicine to our babies. It's also more than that, it's relational. And oftentimes, this is an ongoing thing for families that they may be unable to attain their parenting goals in NICU, and this includes their dreams of what their breastfeeding journey will look like. I had a fascinating conversation with today's guest, and I can't wait for you to see the presentation she has prepared for us. Dr. Elise Graham will be discussing breastfeeding in airway patients, specifically scenarios where parents and baby might be supported to reach their breastfeeding goals despite medical complexity. Elise Graham is a pediatric otolaryngologist, head and neck surgeon, practicing at Children's Hospital in London Health Sciences Centre in London, Ontario. She completed fellowship training in pediatric, this is that word again that I had to learn today, otolaryngology, at the University of Utah after medical school and residency training at Dalhousie University in Halifax. She has a special interest in breastfeeding medicine and obtained International Board Certified Lactation Consultant designation in 2022, as well as an interest in pediatric airway, feeding, and swallowing. She is also the mother of 2 busy boys and a baby girl, and active in education via social media platforms. So I'm happy to be joined today by Elise. Welcome. Thanks for joining us.
Hello. Thank you for having me. It's my pleasure to be here today. I'm happy to be able to speak with you all, and hopefully we'll be able to have a bit of a conversation as well. And I welcome any interaction afterward if I wasn't able to answer the questions that you have.
All right. I'm going to put your presentation up and let you get right to it to share with us what you have to today.
Great. Okay. So as Leah mentioned, I'm presenting to you about supporting breastfeeding in complex airway patients. I have nothing to disclose, but I will say that some scenarios may seem familiar to you or to your life. And this is not by any means a one-size-fits-all situation or a cookbook recipe. And it may not be appropriate for all patients. So obviously, this is the sort of thing that you need to be discussing with your own healthcare team if it's within your goals. My goal is really just to bring the conversation forward and hopefully empower some people to discuss breastfeeding when they might not have felt comfortable doing so otherwise. So Leah sort of mentioned a little bit about me and my background. I'm a pediatric otolaryngologist, head and neck surgeon. I'm also a mom of 3. And breastfeeding is challenging. It's wonderful and it's really rewarding, but it can be very different than you expect, even when your children have no other complexity to consider. So these are 3 full-term little kids, but I had my own share of struggles, particularly with my first, and those struggles led me to go on to seek further training. And so I obtained my IBCLC in 2022. And actually, there's a brand new certification. The North American Board of Breastfeeding and Lactation Medicine just introduced certification for physicians. And I learned this week that I was successful in passing their first exam. So I'm officially board certified in breastfeeding and lactation medicine, one of 103 physicians in North America. So that's pretty exciting, and working towards my fellowship of breastfeeding medicine. Today, I'm hoping to discuss some situations of airway complexity that might not preclude breastfeeding, and discuss how we might support breastfeeding during periods of NPO and separation, and then also some potential ways to troubleshoot breastfeeding in more complex patients. And I know the audience is wide here, and there's some parents and some healthcare providers, so hopefully we have a little bit for everyone. I think no one is a stranger to the benefits of breastfeeding, and these benefits are both for baby and for the lactating parent as well. So as we know, for baby, it improves IQ outcomes, decreases the risk of obesity, decreases the risk of a lot of upper airway infections. And for mom, actually, there's a ton of evidence supporting benefits for mother as well, or lactating parent. Examples would include decreased risk of breast and ovarian cancer. And a properly supported parent, there's a decreased risk of postpartum depression as well. So all kinds of different benefits to both members of the dyad. And actually, this didn't translate super great onto the screen, but we know that complex patients benefit more from the provision of breastfeeding or breast milk, actually. There's been studies in premature infants in general, those babies with congenital heart disease, babies with necrotizing enterocolitis, and we know that these groups actually do a bit better with breastfeeding and breast milk provision than patients that don't have other complexity. However, there's this perception that bottle feeding is easier for a number of different reasons. Some of the concerns are that it's more difficult to measure volumes in a baby who's directly breastfeeding. For example, you can't say baby has taken in X number of milliliters. You have to measure that in a different way with output, with growth, and it's not instantaneous in the same way. There's also an erroneous idea that breastfeeding requires more calories than feeding via bottle, and some evidence has suggested that's also not the case. And so my interest sort of came, it seems like an unusual niche for a pediatric otolaryngologist, but as a feeding and swallowing and airway expert, I'm kind of uniquely, and my specialty is uniquely positioned to try and offer support for airway patients, because people ask us, they may ask, can this baby feed orally or directly at the breast? And I think that it's important that we have that information for parents. I'm going to discuss a couple of case studies, and these are kind of general. They have some flavors from cases that have been published in the literature. The first is a full-term baby boy that's born to a healthy first-time mom, but he had a lot of trouble with his breathing right at birth and required CPAP, which many of you are likely familiar with, right from birth. And then we did a scope examination at the bedside and found that he had a really teeny tiny little airway, actually. So these are the vocal folds that you can see on the screen, and that teeny tiny hole. Usually the entire area between those two white lines is open and black, and he just had a pinpoint, a couple millimeter airway. This little guy had an urgent tracheostomy placed to support his airway. But the question was, this mom came into her journey expecting and hoping to be able to breastfeed and wondered if she could be supported to do so. A second case that we'll sort of use to illustrate the possibilities of breastfeeding is a 1-week-old little baby who was born full term to a second-time mom who was experienced in breastfeeding. This baby had aspiration episodes that were noted, and then had a specialized radiographic swallow study test that's called an NG tube pullback test with barium. And so they did the conventional swallow test, but then pulled the NG tube back to see where the contrast flowed. And it flowed in this little space in between. This is a fistula or connection between the airway and the esophagus. So this baby was diagnosed with a H-type TEF, tracheoesophageal fistula. So it's a connection between the airway and the swallowing pipe. And in this case, we have to ask the baby to not eat anything orally, because anything that is consumed orally goes directly into the lungs. So this baby was asked, we asked this mom to be completely NPO, nil per os, and to be fed via NG tube. And again, this mom had breastfed her previous baby and wondered, is this a possibility or is this off the table for me for this second child? So this is a proposed how-to guide to support breastfeeding in airway dyads. And again, it can be modified for your specific situation, but sort of an example of ways that we might consider supporting patients that are interested in breastfeeding. So I think the first thing and most important thing is whether this is something that's actually within parents' goals. In some cases, we underestimate as healthcare professionals how important breastfeeding is to parents. We think, oh, this is arduous. This is really tough. The parent is not going to want to think about this. And I think in some cases that is the case. Some cases it's just one additional thing to do for families, and they prefer to leave it behind. And express breast milk is not within their goals or their vision of their parenting journey. But for other parents, it absolutely is. And it becomes something that is really important to them. And they really want to be able to do this when it's very challenging, right? To connect with their baby in other ways. And this is something they really feel that they can provide to their baby. And it's really important. If we identify that their goal is to provide breast milk in any way, step one is to help this family with obtaining the ability to do so via pumping if they're not able to have anything NP or orally, or direct breastfeeding if that's within the possibilities. We need to then, after we've decided the parents' goals or determine those with family, we need to build a team. This is not a one specialty situation, just as every aspect of the patient's care is multidisciplinary. Breastfeeding is as well. Lactation consultant is a cornerstone of the team to support pumping if that's the primary modality of breast milk provision at this moment, or if it's direct breastfeeding, we need the lactation consultant on board. Depending on your institution, it may be OT or SLP who assist with swallowing assessment, a dietitian to help with caloric intake, pediatrician to oversee the entire baby's care. And then, in the cases of these airway patients, otolaryngology is involved. We're not always involved in feeding decisions, but in the airway patients, we often are. If a baby is able to feed directly at the breast, we need to determine if the latch is acceptable. Can we improve the latch? We need to have a nice wide gape. We need to have some asymmetry, and we have to have good depth. And this is something that your lactation consultant, I put a little in the corner, maybe who on the team might be responsible for each part. And if there's concerns about aspiration in a baby, sometimes, a breast is never empty. There's always something. But if we try a latch immediately post pumping, there's going to be less volume, less risk of high flow or a letdown. And we can just see if it's something that's comfortable or works for family. The next step is assessing if there is obvious evidence of aspiration or if there are risks of aspiration. Sometimes it's simple and we've got obvious choking and aspiration. Sometimes it's not so simple. We need to follow oxygen saturation and lung status over time. Actually, sometimes the troubleshooting is very simple. We can resolve a lot of improve aspiration with position. For example, a laid back or physiologic breastfeeding position decreases the strain from gravity, essentially. So if you've got a baby who is downward, they're not going to have as much control as if they're above. And then, breast milk is going upward, so there's more control for the baby. Next is to assess transfer. We need to be looking and listening for audible swallows. And this is assuming this baby is allowed to orally feed and allowed to transfer at the breast. There are lots of reasons why that may not be safe initially. You can look for signs. This is a satisfied customer here. Signs of breast milk on the baby's face or lips. Weighted feeds can be a really helpful adjunct to care as well, using a really accurate scale, changing nothing about the baby, weigh them right before feeding, feed them, don't change the diaper, don't change the clothes, put them on the scale and see how much they've transferred. And that'll give you some information about how much baby is actually taking in. And then longer term, we look at things like diapers and the days time frame, and then growth charts on the weeks to months kind of time frame. Next, we can troubleshoot. So if it's not working for X, Y, or Z reason, we can consider whether positioning, such as a laid back position, might be more helpful. Swallowing study of choice sometimes is necessary and sometimes is not. And sometimes if we're looking at oral aversion or we're looking at a baby who's going to have to be NPO for some time, in my institution, it's OT and SLP that might work with them to continue helping them practice their suck and continue oral stimulation in a sort of friendly and low pressure environment to allow them to eventually be successful at orally feeding. So that's a very quick run through of a proposed algorithm for supporting patients who are a bit more complex. I'll talk to you about our cases again so that we can see what we did with these particular patients. This baby, as you may recall, is the one with a really narrow airway. This is called subglottic stenosis, so narrowing below the voice box. And this mom was wondering if she could breastfeed her baby who had a very narrow airway and ultimately required tracheostomy. So what we ended up doing with her, she was supplied with a hospital-grade double electric breast pump. She was supported with lactation consultation and worked towards developing a full breast milk supply via pumping. And actually, the interesting thing is this baby, it took a little while, a couple of days, I think even a week, to fully diagnose him appropriately. So he was actually direct breastfeeding some prior to the tracheostomy OR. So he had a little bit of practice and was doing surprisingly okay given the size of his airway. He needed some supplemental formula as well and was getting some express breast milk, that's EBM, in a bottle. After his trach was placed, we initially fed him express breast milk via NG tube, but we started with breastfeeding practice post-pumping, again, empty breast. It's never completely empty, but with very little volume burden. And the nice thing about a tracheostomy actually is it's easy to assess aspiration because it comes out the trach. I think he had one episode where he had a little bit come out of the trach. And then other than that, there was no issues with breastfeeding in terms of aspiration at all. And he transitioned from NG tube to exclusive direct breastfeeding by post-op day 16. So just a little over 2 weeks after his tracheostomy surgery. And there's a little picture of that guy there. And mom was really happy with that. He actually grew really beautifully too. So you can see the growth chart there. He climbed up a percentile when he sort of found his curve and did really well and continued to breastfeed until I think it was a little bit before his reconstruction. He's actually since been decannulated. So that's a really happy story. And then case 2, as you may remember, is our fistula. So that's the connection between the swallowing pipe and the breathing pipe, who had aspiration episodes and was told that she wasn't able to orally feed her baby at all. So this particular mom was provided again with that double electric breast pump and fed the baby exclusively expressed pumped milk with some caloric supplementation because the baby was having a little bit of issues with growth. So this is, again, the need for the multidisciplinary team, our nutrition colleagues and our lactation colleagues to help with the pump optimization. And then this baby, we waited until she was a little bit older and a little bit bigger to make the surgery safer. So at 3 months, had a successful repair with no leak identified. Unfortunately, after this prolonged period of NPO, baby had significant oral aversion. So mom was trying with bottle to feed baby, and baby just was not having it. No interest in having the bottle in the mouth. And I think that this is something that's commonly experienced as well in the premature baby population. So you guys may all be familiar with an oral aversion. And mom actually at the same time, all throughout, even the NPO periods, she would kind of let baby practice latching a little bit with nothing in her breath or like post-pump, not trying to look for transfer, not doing it for long. And this baby lost her NG tube and mom thought that she would just give breastfeeding a try. And baby did really well, believe it or not. And since mom had a full supply from continuing to pump, she was able to successfully transition from exclusive NG feeding to oral feeding via direct breastfeeding, though baby was a bottle refuser all along. And we're really happy that we'd supported her, and she was happy too. She found it to be a bit of a slog, which exclusive pumping can be. But she was really thankful she'd persisted with it because actually baby was able to avoid the G tube that was scheduled and was discharged from care. So it was really a wonderful outcome. So there's lots of different breastfeeding success stories. There's another published case I have a picture of in the middle there. And there's, everybody's journey looks a little bit different, right? So exclusive direct breastfeeding is not everybody's goal. It's also not possible for every family for any number of reasons, from baby anatomy, latch problems, supply issues, and so on. But for some, it may be some direct breastfeeding, which is also combined with expressed breast milk or formula feeding. So for some families, success looks like just expressed breast milk feeding, and some it looks like just formula feeding. And it's really important for us to assess and meet parents where they actually want to be. But I think it's important to not rule out the possibility of breastfeeding just because we've got a little bit of extra complexity. And there's some other areas where there is data about breastfeeding in complex infants. Dr. Nikki Mills is a pediatric ENT IBCLC in New Zealand, and she published a paper looking at breastfeeding in babies with laryngomalacia and did breastfeeding fees, where she looked at their swallow with a scope at the time of breastfeeding and watched in real time the way that feeding was optimized with different positions. And laid back positioning was a good position for those babies. And laryngomalacia, some may be familiar with, is a condition where the airway is floppy and it's improved often on baby's tummy. So if you can put baby on their tummy, it makes sense that they would feed better as well. So this is something to consider. Other areas, bilateral vocal fold paralysis, unilateral vocal fold paralysis. And then, in patients that require prolonged periods of NPO, I would urge people to discuss with their team about safety, because we don't want to put breast milk where it doesn't belong in kids with significant aspiration risk. But maybe practice latching on an empty breast would be a possibility in certain patients with discussion with the team, even for non-nutritive and comfort reasons. And this is a paper, I think it's open access, actually, I'm pretty sure, supporting breastfeeding complex pediatric otolaryngology diets. So this is the cases in a bit more detail and with the pathway in a bit more detail, if you'd like some more information, in Annals of Otology, Rhinology, and Laryngology. And then the original case report that we published, this is the first case report in the literature of a baby with a tracheostomy breastfeeding. And when I encountered the situation, I didn't review this case with you in detail, but the family asked if it was possible, or I asked if it was possible, and nobody had thought about it before. And sometimes it's just asking the question first and giving it a try in a controlled setting. And this baby did really well. And now the literature is out there, hopefully to support other people, depending on their situation, to think about breastfeeding. So in summary, our group of physicians should be a key supporter or a member of the multidisciplinary team that's promoting oral feeding. And if we can get to direct breastfeeding, if it's within parents' goals, then I think that it's something that we should try to do. There is evidence that exclusive pumping is associated with earlier cessation of breastfeeding because it's very challenging. And, a lot of parents do it, and it's really amazing that they're able to achieve their goals because it can be tough. But if it's within the goals and we can make life a little easier by skipping the step of pumping within the feeding journey, we should try and do that. It should be within our purview to troubleshoot common issues. Just because a baby is complex doesn't mean they can't have the regular issues like inadequate latch, inappropriate positioning. We should try and improve these things. If there are concerns, we should consider swallowing studies to take a better look at things. Another interesting thing that's emerging, Chris Hartnick and his group in Boston recently published a paper looking at breast milk aspiration. And they had a series of children who were told to be NPO but continued breastfeeding. And that small series suggested no increased risk of aspiration in exclusively breastfed babies. But again, this requires more study. So I don't think that we should be advocating for that necessarily in every patient, but that's something that requires more study in the future. And it's also really important that we're celebrating success with our patients, whatever it looks like. The journey might be a bit different than they expected or we thought would occur, but success can look a lot of different ways. And so we need to be celebrating that with our patients. I would love to have some discussion or welcome any questions. It's a fairly short presentation. You can find me on Instagram as well. And I welcome any non-specific patient questions. I can't ever answer any questions about your specific child because I'm not involved in their circle of care, but open to chat or share ideas. And thank you very much again for the opportunity to chat with you today. There's just a few references.
Thank you so much for sharing that with us. That was, as I anticipated and shared before you started, really interesting. And so I have a few questions for you based on your presentation. And the first one, I apologize, I don't think it's an easy question, but what do you think is the greatest hurdle in helping patients with complex airways breastfeed? What is that barrier? Like you said, this was the first time that it had been published that there was a baby with a trach who was breastfeeding. So why isn't this happening more? What's the blockage there?
So I think, I think about this a lot. I think that breastfeeding is not the top of everybody's mind, and it depends on what your team's background is. It is in some ways it's a bit of a challenging question. I agree. There is some literature to suggest that physician and care providers' own experiences with breastfeeding also color the way they advise parents, and sometimes breastfeeding is emotionally charged, and depending on one's own experience, it may be that they overvalue or devalue breastfeeding. So that's one possibility. Like if someone's had a terrible time with breastfeeding and felt it was something that was not right for their family, they may be less likely to recommend or adequately support it in another patient or parent. So that's a possibility, not always. I do think that sometimes it's just like the bottom of the ladder of problems. People are like, this baby can't breathe. We've got a trach, they're good. We can give them a bottle, we can measure the amount they're drinking and get them out of hospital. But that's not complete patient care, right? We didn't recognize a whole aspect of this mom's goals. And just because we don't know, we shouldn't say no. We should explore, see what literature is out there, and if there's anything that we can do to support them. Involve teams, communicate with other specialists, and see what we can do to meet these goals. Yeah.
I know one thing I hear a lot is people will often put their breastfeeding goals to the side in exchange for what they would see as an earlier discharge.
Yeah.
So I hear a lot of families say, we're just going to get to the bottle and then we can get home and then we'll worry about breastfeeding later.
Yeah.
And so in your experience, I know you shared that you had your baby there who was doing breastfeeding 16 days post-op. In your experience, does it prolong the NICU journey or the hospitalization when families are trying to get to this breastfeeding goal?
That's a very valid point. It's different in patients with tracheostomy. It takes a long time to get them out of hospital anyway, because we need to get all the supports in place to bring them home. So there's often like nursing care, equipment, that kind of stuff and support. So I don't think it delayed the discharge in that particular case or in the few tracheostomy patient cases that I've had where this is relevant. I have run into other scenarios where I've been speaking with the pediatrics team and they're like, okay, we're going to get them to bottle. I'm like, well, wait a second. Is that what the family wants? And yes, it may delay things a day or two. I think, that's a reasonable thing to be concerned about. It all depends on anybody's individual values, right? I totally understand and respect the desire to get out of hospital as quickly as possible. I wonder if there couldn't be some hybrid though. Like, could we get to the point where baby's feeding really well at the bottle, but we're also starting to try breast? The other thing that can be challenging is once you got to this point where you're exclusively pumping and you're getting out of hospital, how do you know if you're being successful with the transfer and so on without the support? I think it's a really complex issue too, because I know a lot of NICU parents that do end up exclusively pumping, at least for some time. Like lots of preterm infants, have intubation or oral version or immature suck mechanics and so on. I think that there's some measure of safe feeling too for knowing the volumes for parents as well. So this isn't, maybe it's not for everyone, right? You get into knowing what the volumes are that you pump and you've pumped enough for baby and it's getting into baby. And so it is a bit more uncertainty. One of the top reasons for breastfeeding cessation in anyone is perceived low supply. So whether that's an accurate perception or not is a totally different animal. I answered that well, but it's just that there's so many complex issues about this.
Yeah, for sure. Something that NICU families often worry about because it is one of those things that is more common in our babies. And so you had mentioned that there was baby who had an oral aversion to the bottle, but not the breast. And is that typically how that works? Or
this is a tough, again, oral aversion is not my top area of expertise. I'm one member of this multidisciplinary team, right? And actually looking at the literature about oral aversion, it's not great. There's not great evidence for what to do to prevent it, how to treat it. I've looked at it a lot. That particular family, that baby, if you put a bottle near her mouth, she was just 0% interested. She just, if any liquid, food, nourishment touched her mouth, I don't think she even minded. So it was not complete oral aversion, right? She didn't mind her soother. She just did not want milk from a bottle going into her mouth. That was that baby. But she managed to transition to the breast, and it was not what I was expecting. I had been involved in her care all along and hadn't heard from her for a while, and looked and saw her G-tube was scheduled and called the family, and they said, you know what, actually, this is what is happening. So we had continued with the breastfeeding, and I said, oh my goodness, let me get all your growth charts and stuff like that. And everything was looking good. And so they canceled. I think it's really important what you're saying. This is not a one size fits all, right? And oral aversion is a really complex issue. So just because this happened to work for this family doesn't mean that it's going to work for every family and every child.
I think what it is showing, though, and correct me if I'm wrong, is that you're exploring these different avenues. And so if baby's showing us, I don't like this, then you go, okay, well, let's try this and see what happens. And I like that kind of approach of what you're saying, of that trying, because I think you're right. When there's not a lot of literature out there, and we all do our best with the information we have, sometimes it is just that exploration, especially recognizing that all babies are individuals and what works for some doesn't work for others.
Yeah, for sure. And I think the other thing that's important, communicating with your team about your desire to
Yes.
try new things, because there are going to be areas where it's like, okay, well, it's just absolutely not safe if your baby gets anything in their lungs. Like there are very high risk of adverse outcomes for aspiration. But yeah, it's for us with our cases, we said to ourselves, like, if this doesn't, what are the risks if it doesn't work? We've got a trach we can suction through. We've got other avenues we can use. Is there a harm in trying? Is there a harm of all the things to get in your lungs? I think breast milk is probably the best, right? Other than water. But it's just, we just have to adjust our expectations. And anytime we try something, just make sure we're doing it in a monitored and supported setting with the support of your team. But bringing up the question, right, is, we're trying to get to bottle. Is there any chance that we could try to get to breast as well? Like, could that be another goal, or
Right.
et cetera? Mm-hmm.
Yeah.
Yeah.
When you're talking about different breastfeeding positions,
Mm-hmm.
something that I am passionate about, because we talked about in our prep of how I switched from a cradle hold to a football hold with my middle child, and what a difference that made in her being able to latch without causing me pain. And so I'm just wondering, are these kind of skills, in your opinion, currently at the bedside in NICUs, or is this something that NICUs need to have dedicated LCNs for, or is the skill set there to do this kind of work?
That's a great question. I think it differs so much in different places. There are lots of really wonderful lactation consultants working within hospital systems. So I would say, you need to explore what kind of support is available. Within our institution, we're just about to work towards a sort of quality improvement initiative, looking at how we support our patients now. I think NICU is actually one of the best environments for supporting breastfeeding compared to other inpatient units in the hospital, because it's something that's on people's minds. But I think NICU has the best skilled people, probably, along with mother baby unit, right? But those patients who later come into hospital, like someone who's admitted with a baby who is sick and needs, a pyloric stenosis revision or something like that, are they getting breast pumps while they're NPO? Are they, being helped to support breastfeeding? Or what about the patient who's admitted, who's 5, but actually they have a baby brother at home that nobody's thinking about, and this is a pumping mom who is not getting supported to continue breastfeeding and risks mastitis and so on. That's a partial answer to your question, and another side issue as well. I think it's very individual, so I couldn't answer that. I think that there's a huge variation in the ability and availability of supports, and it sort of requires exploration within individual sites.
I'm going to wrap up our time together, but wanted to end with asking you what advice you would give to families who have babies who have these complex airway complexities in NICU. What advice would you have for them in meeting their feeding goals?
So I think my first advice is, I feel like every parent deserves like the congratulations, and this is you've got your beautiful new baby. It's not the way that you expected, and no matter what happens, like the right thing is going to happen for your baby, right? Like what you're doing is the right thing for your baby. I feel like there's a lot of, again, guilt, emotional turmoil involved in breastfeeding, and people tie their self-worth sometimes as a mother to their breastfeeding experience, which is like a really challenging and like cultural issue, right? So no matter how it works out, your baby's going to be fine. From this perspective, your baby's going to be fine. If your goal is to breastfeed, bring it up with your team. Continue to access the supports that are available to you. Ask for be an advocate for yourself. Ask for lactation support. Ask for pumping support, because pumping is going to be what allows you to develop the supply that will allow you to feed your baby if breast milk is part of it, right? Pumping is challenging, and you'll need support for it. If direct breastfeeding is within your goals, speak to your team. Mention that you've seen it, that it's been done in certain populations. Maybe that's helpful, because then there's literature backing. But just be ready to pivot. And I think preemie parents are often their best self-advocate, like wonderful self-advocates or advocates for their babies. And this is an area where hopefully knowledge will increase. There's an area for future study, and there'll be more and more that people know about and can do for these babies in terms of feeding directly at the breast.
Well, thank you for sharing with us today and for sharing those successes, because you're right. When we know that this is happening out there, then it does help prepare families and parents to advocate for themselves and their babies when they're in NICU and want those goals, to obtain those goals that they have dreamed of. So thank you so much for joining us and for sharing your expertise with us.
It was my pleasure. Thank you very much. And again, if anyone would like to connect, I can't talk about specific patient scenarios, but healthcare providers or anyone would like to chat, I'm available on Instagram.
Thank you so much.
Day. Thank you.
And thank you for joining us today for this edition of Preemie Chats. This is sponsored by AstraZeneca in collaboration with the Canadian Association of Neonatal Nurses and Family Integrated Care. Just a reminder again that if you missed part of today's episode, or if you want to rewatch it or see any of the past episodes, you can go to CanadianPreemies.org. There you'll find many resources and support, and you'll be reminded that CPBF is a charitable organization and it depends on support to continue its important work. If this is a time of year for you where you purchase gifts for loved ones, think about giving a donation in their name and supporting CPBF's mission to empower families of premature babies every step of their journey. Together, we can create a brighter future for all preemies and their families. I hope that you're available to join us here next Friday at 1 p.m. Eastern Time. We're going to be looking at language development of preterm infants, what parents need to know. You won't want to miss that. So I hope you're able to join us. And in the meantime, I hope you all have a great week.